The Division of Cardiothoracic Surgery at Indiana University School of Medicine is a very diverse and talented group of cardiac surgeons, thoracic surgeons, and congenital surgeons that are truly a talented and unique group of faculty. At Indiana University School of Medicine, our mission is to be a global leader in academic cardiovascular and thoracic surgery, as well as educate the next generation of surgical leaders and deliver compassionate care to the citizens of Indiana.
Where our center is at IU, we're fairly centrally located within Indiana. But what that means is that patients from all around the state, when they have an aortic emergency, need to get to us. On average, we can get patients to our hospital, in our facility, in our operating room within 3 to 4 hours. We can provide a full range of services for all patients. We have a wide range of tools in our toolbox, including devices and your traditional open operations. And so we can essentially take care of the entire aorta from start to finish. Innovation has been just a huge help to how we treat our patients, and the outcomes have shown that our patients are doing better.
Putting a pump into the right side circulation of a Fontan patient is a complicated thing. It's a 4-way flow problem. It's not a 1-way flow problem. There is a risk or a concern about device obstruction, blockage of blood flow, and it's a pump that has to operate at a low pressure. Those are the main design objectives that had to be thought about and overcome. We're at the tail end of a major NIH R01 grant, which funded a lot of the basic R&D to develop the basis of the pump. We're now doing animal studies and fine-tuning a few things. The next major transition or milestone is to shift to commercialization development.
Throughout my career, and especially over the last 10 years, I have really pushed myself to become more active in academic cardiac surgery, really to encourage women to go into cardiac surgery.
Historically, and still today, women undergoing coronary revascularization have worse short and midterm outcomes, despite adjustments for comorbidities and age. Women tend to have smaller caliber vessel and more diffuse disease, making them more technically challenging for surgical revascularization. Also, historically, women have tendency to receive saphenous vein grafts compared to arterial graftings, which have known shorter long-term patency rates. They also have been underrepresented in prior trials, limiting confidence that male-dominated evidence applies to women. So the Roma and Roma women trials are addressing these gaps by directly comparing single versus multiple arterial grafting in women, and their results could be practice-changing, potentially establishing multiple arterial grafting as the new standard for women. So we need to build programs where trainees feel supported and empowered to grow. That means diversifying leadership and faculty voices, modernizing feedback and evaluation systems to reduce bias, and prioritizing psychological safety where trainee can ask questions and learn openly. We also need to create a culture that values well-being as much as clinical and academic excellence.
I think what's important with diversity is leading by example, that, our professional duties are gender neutral, and so is our ability to deliver those skillfully. And so I think when you demonstrate that to younger trainees and younger women by way of example, that's the way we embrace the younger generation's ability to move forward in a field like cardiac surgery. What attracts me to global health is, if I don't do a cardiac operation here in Indianapolis, there's 20 other able colleagues who can. But there's plenty of places in the world where there's no heart surgery, in the village, in the city, in the state, in the country, in the neighboring countries. And so I think that really resonates with why we all went into medicine, right? The ability to give back where there's no other opportunities. Recently, we found ourselves in Kenya with an all-female operating room team. And so gratefully, that's a little more common now today in the U.S., but to have that happen in sub-Saharan Africa, where you look around the room and I'm assisting a female Kenyan cardiac surgeon with her female perfusionist and female anesthesiologist and cardiologist, with all of my supportive team being female, it was really a remarkable moment personally and professionally, and it's not something that I'll forget anytime soon.
We are all one people. We are separated by culture and religion and politics, but at the end of the day, every family I've ever run into has had the same concern. What can I do for my child? We've done north of 650 children outside the country, and I would say 90% of them likely would never have made it to surgery. It's wonderful to see how the families are made whole when their child is well. I found it to be one of, if not the greatest, team-building exercises. So what we do out of the country together makes us better at home.
It's a really exciting time in Indiana. We have a really world-class faculty with many talents, specialties. We're bringing new clinical trials and innovation to Indiana. And I'm really proud of our faculty for who they are, what they represent, and how hard they work. What's most important is to just have passion to serve patients and to dedicate our careers to doing a great job and loving what we do and really improving the lifestyle and quality of life for the patients of Indiana.
Thanks for watching, but now an important disclaimer. The content of this video is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Viewers should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.